Hello everyone and welcome back to Rheumatology Digest. I'm your host Dr. Srihar Reddy. In our clinics, we often talk about disease as a static destination, but the reality is far more fluid. Today, we are exploring four major shifts in our field that prove how dynamic rheumatology has become, moving from mimics of spinal disease to bioelectronic breakthroughs that bypass the pharmacy entirely. We are covering the evolution of sacroiliac joint in new mothers, a potential heavyweight in gout management, and the surprising negativization of antibodies in antiphospholipid syndrome, and a pivotal trial in vagus nerve stimulation for refractory RA. But before we get into the data, I request you to check out our WhatsApp channel for the visual summaries of these papers and more. You can find the link in the description. Now, let's get started. Most clinical headaches begin with a simple question: is this actually a disease? To answer that, we have to look at the iliac bones for the first time mothers. Differentiating mechanical stress from true axial spondyloarthropathies in postpartum period is a minefield. If we misinterpret the MRI, we risk labeling a healthy woman with a lifelong inflammatory diagnosis. Now, in the annals of traumatic diseases, Kill et al. Give us a masterclass on evolution of osteitis condensus ciliae, commonly called OCI. This isn't just a pregnancy-related change. It's a specific structural response to mechanical load. When you are looking at these scans, location is everything. Unlike axial SPA, which can be diffuse, this team found that OCI-related sclerosis and bone marrow edema are predominantly located in the upper, middle, and anterior portions of the iliac bone. Another high value insight is while we think OCI as bilateral, it was actually unilateral in 52% of women at 12 months. Bilateralism reached only 48% at the 1 year mark. So don't let that unilateral lesion trick you into a sacroiliac diagnosis. The important caveat here is the 8 threshold. This study identifies a specific biomarker in the bone, a sclerosis depth of 8 At 12 months postpartum, women with sclerosis at or above this 8 threshold were significantly likely to meet the ASAS criteria for sacroiliitis based on BME and fat lesions. Essentially, the deeper the callus, the more likely you are to see inflammatory looking signals. Now, coming to the evolutionary timeline, the data suggests a fascinating causal hypothesis. The inflammatory signal actually precedes the structural scar. At 3 months postpartum, we hit the inflammatory peak. Bone marrow edema is at its highest as bone reacts to the trauma of delivery. And at 12 months postpartum, the bone is essentially scarring over. The BME declines while the subchondral sclerosis and fat lesions, which are the structural signatures, they reach their peak. The bottom line, if you see deep sclerosis, that is more than 8 in those anterior quadrants, think mechanical remodeling, not necessarily an autoimmune process, especially since these lesions showed no association with actual back pain. Now let's shift from mechanical strain to metabolic crystals. We are in the midst of a global gout crisis, and quite frankly, our standard workhorse, the febuxostat, often leaves us wanting more. In many populations, responder rates for febuxostat of 40 mg hover below 50%, particularly in our difficult to treat patients, those who have high BMIs or severe baseline hyperuricemia. In the Arthritis and Rheumatology Journal this month, Sun et al. Published a phase 3 trial comparing febuxostat to a new contender, dotinurad. Now, it's important to distinguish the tools here. Febuxostat is a xanthine oxidase inhibitor. It stops the tap from running. Dotinurad is selective URAT1 inhibitor, which is an uricosuric that helps the drain work better. Since many of our high BMI patients are actually under excretors, dotinurad hits the underlying pathology directly. The primary endpoint was the responder rate, that is, serum urate levels of less than 6 mg per dl at week 24. Dotinurad 4 mg didn't just win, it dominated. doubling the efficacy of the standard care. Coming to the safety profile, both of the drugs were well tolerated, with one case report of AKA in the dotinurad group and elevated levels of AST and ALT in the febuxostat group as expected. Now, for those patients starting with urate levels more than 9 mg per dl or a BMI of more than 25, dotinurad looks like a powerful new option for achieving serum target levels where the xanthine oxidase inhibitors fail. Now, moving into the realm of autoantibodies, we need to discuss antiphospholipid syndrome. Traditionally, we have viewed APS as a static lifelong sentence of high thrombotic risk. However, Gasper et al. Just published a retrospective cohort study in rheumatology that challenges this static view. They looked at APL negativization, defined as two consecutive negative results for solid phase APL, that is, for both is anticoagulation and anti-beta 2 GPI, at least 12 months apart. Note that they excluded lupus anticoagulant from this follow-up definition because LA testing is notoriously unreliable while a patient is on anticoagulation. The clinical payoff for negativization is massive. After achieved seroconversion, the risk of recurrent thrombosis dropped by a staggering 88%. This held true even after adjusting for age and type of initial thrombosis. Who is likely to recur and who is likely to negativize? The study found that hyperlipidemia at diagnosis was a major red flag, more than doubling the hazard of recurrence. Now, coming to key recurrence predictors, persistent triple positivity patients are least likely to achieve negativization. Also, the stroke or MI at onset predicts a much rockier future than venous events, and older age of first event increases the hazard too. Okay, while we aren't ready to pull the plug on anticoagulation yet, the authors correctly note that this is a hypothesis generating. It does suggest that serial solid phase antibody monitoring could help us identify those low risk subset patients for future individualized management. Let's look at the fourth pillar of rheumatology. We have drugs, but what about electricity? The RESET RA trial, recently published in Nature Medicine, investigated vagus nerve stimulation to engage the inflammatory reflex. This wasn't a mild RA study. 43% of this cohort were classified as difficult to treat, meaning they had failed multiple biologics or targeted synthetic DMARDs. The data is very encouraging. At 3 months, the active stimulation group achieved ACR 20 levels of 35.2% versus 24.2% in the sham group, while at 12 months, which is open label, the response rate matured. The ACR 20 rate climbed to 52.8% by 1 year. Now, as a consultant, I am less interested in just feeling better and more interested in the bone. In patients with erosive phenotype, that is, those with baseline synovitis or osteitis, active stimulation significantly reduced the progression of bone erosions. We are literally seeing the nervous system protect the joint architecture from being eaten away by the inflammatory process. Now, the set point device is generally safe, but we must be honest with our PEs about the perioperative risks. Serious adverse events happened in 1.6% patients, and usually they were related to surgery itself, including vocal cord paresis and pharyngeal perforation. However, once past the surgical window, the stimulation was well tolerated with a 78.1% of patient satisfaction rates. Well, that brings us to the end of this rheumatology digest. We have seen how the SI joint scars over after childbirth, how URAT1 inhibitor might actually finally solve the xanthine oxidase inhibitor refractory gout patient, why we should be monitoring solid phase antibodies in APS, and how bioelectronics is carving out a space for our difficult to treat RA patients. These papers represent a clear move towards a more precise longitudinal understanding of our patients. We are no longer just treating a diagnosis, we are managing an evolution. Now, if you want to see the visual summaries of these papers, the link is provided in the description to join our WhatsApp channel. I am Dr. Srihar Reddy. Thank you for listening. Stay curious, stay evidence based, and I'll see you next digest.